website. We are also offering CME credit for this. So you can go to the SurveyGizmo link, the same one that you've been using the last few weeks to claim your credit. As I said, tonight's panelist is Yvonne Maldonado, MD, MPH. Dr. Maldonado and I have known each other for many, many years, and it's wonderful to be able to have her come and talk to family physicians. Bonnie, what are you seeing? Where are we with testing? Let you kind of explain the environment as you see it. I know that you are intimately involved, and I've seen you probably on 24 Zooms in the last week and a half talking about these issues.
Well, thank you, Shelley, and it's really great to see you. It's unfortunate that we haven't been able to see each other outside of COVID time, but we will soon, I hope.
Yeah.
So as you probably know, it took a while for the testing efforts to really get underway across the country. So fortunately, at Stanford, we were able to develop our own PCR test back in early March. So we started testing at Stanford the first week of March, and so far have done over 72,000 tests. They're very accurate. I think we're better than 95% sensitive and 99% specific. And so we have seen, we were helping a lot of the testing other facilities in the Bay Area who just hadn't built the capacity yet. And so more and more sites have their own capacity now. The governor would like to see somewhere on the order of 150 people per 100,000 population tested in each county. And in the Bay Area, most of the counties actually have set their bar a little higher at 200 people per 100,000 tested. And the reason for that is to be able to get a handle for what might be going on with potential increases in disease over time. Obviously, we don't know anything about this virus, so we don't know if it'll kind of dissipate over time. Is it seasonal? Will it continue? And this is a really important way for us to track across the state as well as in other states around the country. And so most of the counties are getting close to their target. Not all of them have reached it. And we're hoping that we will get there in Santa Clara County and San Mateo County soon. And testing, tracing are really critical, and I'll say why. Obviously, most of you know that we don't have treatments or vaccines for this virus yet. And because of the way it's transmitted, the transmissibility of this virus is moderately high, but we will need somewhere on the order of herd immunity or population-based immunity of anywhere from 60 to 80%. That's 60 to 80%, in order for us to estimate that we will stop transmission, widespread transmission. We're nowhere near that. We're generally about 1% population infected right now. In some populations in California, maybe as high as 5%. In the East Coast, we're talking about in high-risk populations, maybe 20%. So we're not anywhere near that level. The only way we can really prevent a sustained transmission is really just behavior. And so testing becomes really important.
Right. I'm from the Imperial Valley and have seen the numbers in the Valley increasing dramatically. And we're seeing the numbers in our underserved population, the minority communities, increasing as well. Something we should have expected? Is there something special we should be looking at? Is there something family medicine could be doing to make sure that we're helping those communities with their issues?
Absolutely. I think it took us a long time to really even start to consider what was happening in our racial and ethnic minority populations. And as far as we know, and of course we know very little about this virus still, we're not sure that there is a genetic predisposition. There may be some evidence of risk factors, for example, age and underlying comorbidities. But in the racial ethnic minority populations, really, we're talking about generalized health disparities. So, for example, if you look at our Black and brown populations, they're more likely to be in essential services that are not in healthcare provider settings. For example, public-facing grocery stores, transit, et cetera, where they may not have access to appropriate PPE, or may be living in really dense living conditions, or be working in densely populated areas. So this is really an exacerbation of existing health disparities in those populations. All of the things that we need to do, for example, face masks, distancing, hand washing, hand hygiene, are just things that may not be available to a lot of these populations. And so I think our providers should really be aware of that. Obviously, within their own practices, I'm sure many people are turning to telehealth so that you can at least start to talk to people and maybe educate them somehow by telehealth or other messaging without having to have them come into your offices. But if you do have ways to screen for people with symptoms and there is no access to testing, the best thing you can do is at least to ask people to stay home or to try to access testing sites. The state health department has links on their COVID website to zip code based ATSs or alternative testing sites, so that everyone should be close to a place where they could get a test if providers can't offer them.
Right, and clearly for some of these populations, the isolation issue, we're asking you to isolate for 2 weeks is really almost impossible. If you look at audiences with dense housing and the like.
Yeah. Well, we've had, for example, we're running, and we could talk about this later. We have a big outpatient treatment, actually outpatient trials unit that I'm co-directing with one of my colleagues. It's called a COVID Translational Research Unit, or COVID TRU. We currently have 2 studies going on in the outpatient side, and we're lining up to try to get a third treatment available for people who would like to be treated or participate in trials. And one of the families who came in was really a good example of what's happening. We're seeing more and more of this epidemic occurring in racial and ethnic minorities, even in the Bay Area. And one of our patients who came in to the hospital, actually, he and his wife are both infected, but the wife, one of them, they had 2 kids and there was nobody to care for the children. So the husband was sicker, although not much sicker, but he was sicker. And so they elected that he would be hospitalized, and she actually went home pretty sick to take care of the kids. So we're just talking about a really a disproportionate impact on some of these families.
Yeah. We have many of our members, obviously our family physicians practice across the spectrum and everywhere from solo rural practices to larger urban areas, and Stanford and UCSF and UCLA and Permanente. But we have many of our members who are in smaller private practices, and wondering, and many of them have seen significant drops in patient population, because outpatient and regular, quote unquote, regular care has been slowed. Many of them are worried that we might be reopening too quickly and getting started too quickly. What are your thoughts on that?
Well,
we clearly are going to see another surge. We have to, with Memorial Day crowds and now protesting crowds and soon 4th of July crowds.
Yeah, well, I don't even know that it would be a surge, since it never really has gone away to begin with in many places. We kind of flattened out a few weeks ago, and it's been, that flattening was great compared to, say, our colleagues in the Northeast of the US, but it really hasn't dropped off very much, if at all, in California. And I guess we never really expected it to go to zero. What we were hoping to do was flatten the curve, so that we could at least deal with the number of cases. And that was really helpful for us to be able to deal with it. But I do think that there may be an increases in cases. We are starting to see little blips here or there. And I do think that one of the issues that you brought up around bringing people back to care is really critical. So in our hospitals all around the Bay Area, we really had to, it was mandated that we really, well, not mandated, it was highly suggested that we cut back on all our electives, because we really needed to ramp up beds for a potential surge. And we were successful in doing that, but we lost a lot of our other patients. And I think people are afraid to come back to care. I think every healthcare system that I know of has been messaging very strongly across the country to tell people, come back, get care. that you need. We are seeing a decrease all around the world in cancer diagnoses, in stroke diagnoses, and it's not because they're not happening, it's because people aren't coming in. And we know that it's critical for people to get back in for these things so that they actually do better. Obviously, their prognosis is better if they're seen early. So any messaging that people can get out there within their own network of practices is really encouraged. I think what we're trying to do is see if we can provide guidance for, and the CDC has provided some guidance for how you can manage your practice so that you can be careful with patients. And obviously the easiest thing to do, as we talked about, is to encourage telehealth. I know it's hard for people to get access in some places to telehealth, but that is something that is being done and is being reimbursed. I'm not sure that it's being reimbursed at the levels that we would see for in person, but there are efforts to increase that telehealth reimbursement, and they are being reimbursed. Testing is also going to be reimbursed as well, so that should be cost neutral for everybody. One other area I need to talk about is immunizations are just plummeting. It's really disheartening to see that. And while we are saying that if you have to, you can really limit the number of immunizations for older kids, we really need to make sure those under 2-year-olds are getting their immunizations. So yeah,
that's a big concern for obviously for you as a pediatrician, but also for family docs who see kids a great deal. So that's really important to them. What do we know about long immunity? How long immunity lasts once somebody's infected and survives it? Is there an immunity? Do we know how long it lasts?
Well, virtually nothing, frankly. So we do know what happens with, so there are 7 human coronaviruses, 7 that we know of. This is the 7th. 4 of them are seasonal coronaviruses that we have seen for many years. These are normal coronaviruses that cause about 30% of the colds that we see in the winter and in the fall and winter time. And so we know that those viruses, unfortunately, do not provide lifelong immunity. They are a short duration immunity, and people can get reinfected with regular seasonal coronaviruses. There is evidence that the SARS virus, which started in 2002 and disappeared around 2004. We don't know much about it because it went away, but we do know that people who did get infected and recovered did develop neutralizing immunity, meaning they could inactivate the virus. And that immunity in those people, if you look at their blood now, it appears that there was long-lasting immunity to SARS, but we don't see that virus anymore. And there's evidence that not the same evidence for MERS, which is the other coronavirus that emerged in the middle of the 2012 or so. For this virus, we do know that people do make antibodies for sure, so that's good. We know you can make IgG and IgM. We know that in people who have recovered from the disease, that there is evidence of neutralizing antibody, which appears to inactivate the virus, at least in a test tube and in the laboratory. But the bad news is that not everybody who's developed disease and recovered has developed these neutralizing antibodies. Only a proportion of people do, and the titers of the antibody seem to be relatively low. So we have some work cut out for us with the vaccine, because that has vaccine implications. But the good news, at least, is that there is neutralizing antibody that's developed. And we are doing a study at Stanford in collaboration with UC San Francisco and Zuckerberg San Francisco General Hospital to follow 7,500 people around the Bay Area over several months to follow them for new infection and for antibody development over time. So we're enrolling people who have not had infection and seeing what happens over time to see if they develop infection and immunity. And if they do develop infection and immunity, we're going to further study that immunity to see how long it might last and whether it protects people.
Great. So who would you, and I get this question all the time, I know you get them being in the medical world, I'm just kind of tangentially in the medical world, but get the question from friends and family and others. Who do you recommend get tested?
Well, certainly if people have symptoms such as a fever of 100 degrees or greater, or if they just feel like they have a tactile fever, you don't even have to measure it. Somebody has a fever, if they have a cough, sore throat, fatigue, shortness of breath, those are people who should be tested for sure. And you might say, well, why should they be tested if there's no treatment? But those are people who could potentially be infectious and infecting other people at their workplace or in social situations. And actually there are symptomatic types of treatment that are available for people so that they can stay home and rest and not progress. And as I mentioned, there are now outpatient trials available for people to be able to consider enrolling in if they want to see if there might be eventually a treatment for this virus. So that's the easy one. The hard one is, what do you do about asymptomatic individuals? And I would say that that has not yet been determined. So for example, in a healthcare setting like ours, like at Stanford or other academic medical centers, we've tested about 12,000 of our 15,000 healthcare workers. And we found a very, very low rate of infection, less than 2%, probably around the order of 1 to 1.5%. And all of those none of those have been documented to be in hospital transmissions or infections. So we think that represents the baseline community transmission rate. But we have not, we have stopped testing our healthcare workers because we've tested so many and have seen few infections, but we are testing through occupational health people who are symptomatic. And if we start to see hotspots, then we would likely recommend that asymptomatic individuals be tested as well.
Tested. I get questions about the efficacy of the test. Clearly there's the nasal swab, which my brother-in-law said felt like he was having his brain swabbed.
Yep.
Versus the saliva versus the others. What would you tell patients and about the efficacy of these different tests?
Well, it depends on where it's done. So obviously every test is developed in a different institution. Here at Stanford, as I said, our test is very highly accurate. So, so for example, there's something called, I won't get into the details, there's something called pre-test probability and post-test probability. Because the pre-test probability, meaning the risk of you being sick with virus, even if you're infected with virus, even if you have symptoms, is so low, because we know that the prevalence of infection is about 1 to 5%. Mm-hmm. So the likelihood that even with symptoms, you are only about 1 to 5% likely to be infected. The false negative rate on a test is going to be extremely low, like on the order of maybe 0.5%. So it's very, very low at most institutions, I would say. At ours, it's for sure that low. But you really want to make sure that if you're going to be testing people, you know what the numbers are for the test laboratory that you're going to. Most big academic medical centers have pretty good sensitivity specificity. Quest has very good data as well. I'm not trying to advertise for them, but they have pretty good data. And there are other groups. I think Virologics is one, and I forget there's another big lab that does testing as well. I think it's called LabQuest or LabCorp, something like that. So most of them have reasonably good data. So I would think those would be great. Now there are a number that are now offering, home test kits and drive-throughs through pharmacies. Those are not very good, I have to say. In general, the testing is about a flip of a coin. So why would you do that if you are not going to be likely to get a good result? So I would stick to the reputable lab-based tests. And I would love to see a good test at a pharmacy where you could just drive through and get a swab. But they need to do a better job of getting their accuracy up. I will say, again, not to plug anything we just did, but we just published a study here at Stanford. I just finished it just got released through JAMA on Friday. And we actually showed that you can use just nasal swabs. So just like the tip of a Q-tip depth. So not all the way, not a brain biopsy type swab, but just right in the tip of the nose. If you swirl the little Q-tip, and they have to be special swabs,
Yeah.
But if you just swirl in the nose, nostril on one side 4 times and swab in the other nostril 4 times, an individual can actually do it themselves. And it's just as accurate, and you get the same results as if a doctor or a nurse or a healthcare provider does it. So we're actually going to be piloting home test kits using this method pretty soon through a collaboration with the Chan Zuckerberg Initiative and the BioHub, to see if we can actually start doing home test kits so people could just do it on their own. And then you don't have to do that invasive test. And you can also avoid exposure of people coming into clinics or having to wear PPE and all of that. So we're just waiting. So that's for symptomatic people.
Mm-hmm.
We're almost done with our next study, which is to look at whether asymptomatic people can swab themselves and get the same results on a nasal swab compared to the deeper swab, because it may be that asymptomatic people have less virus. We don't know that for sure. So we're almost done with that study. And if that's the case, then we could really just tell people, look, here's a bunch of cute swabs, take them home and you can swab yourself, or you can order a swab online and it'll,
send them in and
Yep.
results sent to your physician.
Mm-hmm. So we're getting
Great.
close. Mm-hmm.
Thank you. Just want to remind our viewers on Facebook, if you have a question, pop it into the chat box. We have a few more minutes with Dr. Maldonado before I have to let her go, and she's got another Zoom to be on, I'm sure. But if you have a question, please pop it into the chat box and Josh will get it over to us. Bonnie, what recommendations, if you had 3 things that you could tell the family physicians with whom you work about what they should be doing, what they should look forward to as offices are opening, as more and more communities are becoming more open, kind of 3 things that we should be looking for and helping our members tackle, because they are the front line.
Absolutely the front line. And we are so dependent on these groups. And I have to say, I guess if I were to do that, I would ask people to really investigate the best way. Maybe this is something, Shelley, your group could help with, how to do telehealth. Because I find that, at Stanford now, we're doing it reasonably well, but it's a big organization with lots of resources. And I have heard from a lot of my friends, even in reasonably middle-sized organizations, that they're having a hard time just figuring out how to do the telehealth. And that would really go a long way to getting people back on their feet, to come back in and have some confidence in their healthcare system, and also for practices to survive. I'm really worried about our practices. So getting telehealth is really a good way to start. The other thing I would do is look at ways to find resources around answering COVID questions and getting communications out to patients. I know it's expensive to do radio and television ads, so only the big health systems can do that. But if there's ways, you can push it out in social media or even centrally through your organization to get that word out for people to push the information out that we're open for business, because we really need I think just getting people back in for all their usual care, that's very important. And then finally, I think people should really be careful. They should really try to make sure that they let people know what they should be getting tested for. There is guidance from CDC. The state has a great website. I would provide references for our providers, our frontline providers, so that they know how to message about this disease in particular, and FAQs for providers to put out even on their websites or however they can do that so people can read.
Right, great. Yeah, and family docs have really taken up the telehealth banner, and I don't think they're going to go back. I don't think patients want to go back to the other way.
Yep.
I do have a couple questions for you. One from Dr. Simon. Could you comment on, if a parent is infected, how likely is it that a child would be infected? And can moms breastfeed babies wearing a mask versus pump and bottle feed?
Yeah, so we don't know the answer to that. It's really a mystery about children. This appears that children, first of all, it does appear that children can get infected. We've seen infected kids. We know that kids are infected. They can get pretty sick, but most kids don't seem to get that sick. And we have also heard about that weird Kawasaki-like disease. So that's extremely rare. So we know children can get infected, and they're probably getting infected from their family members. So yes, that's probably the route. And what's interesting, it's usually the flip side. That is, usually children are usually the reservoirs to infect family members. But in this case, it seems to be the opposite. But we're learning more about that as we go along. And then what was the second part of that? I'm sorry, Miss.
A comment about moms breastfeeding.
Oh yeah, moms can, we actually have been very careful. The American Academy of Pediatrics, I work with the American Academy of Pediatrics on this, and we've been putting out a lot of guidance. You should go just Google aap.org, and there's lots and lots of a lot of information about camps, schools, testing for kids, newborn care. We have really been working, in fact, that's what I'm working on. I had just went through 3 policies today and again, there's very little evidence, but we're providing as much guidance and really bulleted 1-page guidance that people can just follow easily. But we think that if a mother's infected and she's really careful and can do it, we are saying that babies can breastfeed. There's no evidence that the virus can be transmitted by breast milk at this point. Now, again, it's early, but we have not seen evidence of that. But we really want to make sure that the mother does not expose the baby to her respiratory secretion. So wearing a mask or a face covering, making sure that she washes her hands, does not touch her face, and that she holds the baby carefully to make sure that she's not infecting the baby in other ways, but the baby can breastfeed.
Oh, that's great. That's great. But another question from our Dr. Cushing with respect to the efficacy of testing. Some mixed data about how long after an exposure someone should be tested in order to have an accurate result. Could you comment on the benefit, if there is one, of having potentially exposed patients who are not yet symptomatic wait till the first symptoms show?
Yeah, so that's a good question. We're still trying to figure all that out. But in general, what we're doing here at Stanford, for example, is there's a lot, well, I'll tell you what the literature generally shows that people, the incubation period can range from 2 to 14 days. So you don't want to test right away. So if somebody just got exposed yesterday, you probably don't want to get the test today. But so what we're doing, and again, we're in a healthcare situation, but really all around, everyone should be wearing masks anyway, even if they're not working in a healthcare environment. So if somebody is not symptomatic and they're wearing a mask and they're practicing social distancing and hand hygiene and they're not symptomatic, as I said, you could probably wait till day 5. That's probably the best day after exposure, if you know the exposure date, where you're most likely going to pick up a positive. And some people actually would follow it up with a test at 14 days. But I think if you had one to pick, I would pick day 5, knowing that there might be a few days as early as 2 days after exposure where they might be positive, but the most likely day is around day 5 or so.
Great, thanks. We have a question about vaccines. Of the many COVID-19 vaccine trials, are there any candidate vaccines that you think might be more promising than others?
Ooh, that's hard to know. They're all interesting. The Moderna vaccine, the one that was tested in the rhesus monkeys in the UK, was the first one out of the gate because they had been testing a vaccine against a different coronavirus called MERS. So they were able to switch over to that one quickly. They had data right away in monkeys that it produced neutralizing antibody. And that vaccine is already being tested in over 500 people, and they're going on. So they may actually have something a little earlier than others. I think they're talking about thousands of patients that are enrolled now. The problem with that vaccine, it's an mRNA vaccine. It's not a traditional vaccine that we expect, say, like a subunit vaccine or an inactivated vaccine. This is actually using mRNA. And technically, I think that's going to be a challenge to build out, and scale it up. So, and no vaccine has ever been licensed using that technology. So it is exciting and interesting, but whether it can get all the way to the gate, to the finish line, isn't clear yet. There are a bunch of other vaccines, though. There's over 140 vaccines that are being tested right now. So I do think that I'm just a fan of your, garden variety subunit vaccine. We know that the spike protein, the surface protein, is probably the best bet at this point, but I wouldn't limit myself to just that one because there's obviously, we don't know enough to know whether that's going to be good enough. But I would say that subunit vaccines are great. We know they work in general. And if you could target the spike protein and you can produce neutralizing antibodies with that, then I would say that might be the best mechanism. But having said that, there's a lot of them out there. I don't think we're going to have, I mean, some people have said there will be a vaccine by the fall. That's only a few months away. Not going to happen. I think we're talking about sometime in the next year at the very earliest. But again, I think there could be treatment. So we know remdesivir is not a magic bullet, but we know remdesivir can work. There's further trials with other formulations of remdesivir. There are other antivirals in the market that are being studied now. So I do think that there may be some treatments available for the outpatient and the inpatient setting. And eventually we're hoping that there could be treatment to prevent transmission from one person to another. So they may all come about earlier because it's easy. I think it's easier to test antiviral compounds than it is to test vaccines, but hopefully in the next year or so.
Right. And in the meantime, we of course need to think this fall about flu vaccine.
Oh, absolutely. I'm just finishing reviewing the AAP vaccine policy. By the way, the AAFP actually endorses our policy, and we usually follow the CDC's policy. So as soon as I can get that done tonight, it's going to go to our board, and then hopefully get a preprint out for people to look at. But basically, flu vaccine is critical, if only to prevent one more febrile respiratory illness in the fall, because you're not going to know what it is. And by the way, while we're talking about that, there's no evidence that you can only have one at a time. So in fact, there's been publications showing that you can actually be co-infected. So if you have somebody who has a fever and they have a test for the flu positive, don't think they might not also have COVID either. So you need to actually think about more than one virus, unfortunately.
Yeah. Does kind of make you want to stay in a cave until
yeah. Or wear a mask.
Well, we're all wearing masks.
Yeah,
we're all wearing masks. Bonnie, I know you need to go. I just want to thank you for spending time with us this evening.
Sure.
Lovely to see you. Hello to the family.
You too.
We will catch up.
Yes.
And we really appreciate the time that you've given us this evening.
Thank you so much. And if people have other questions that they send to you, I'm happy to try to answer them offline as well.
Okay, super. Thank you so much.
Take care. Good to see you. Thanks. My best to the family. All right, take care. Bye-bye.
Take care. For you on Facebook still, we do want you to remember that we have COVID-19 information on telehealth, on our resource page, on some of the response pieces from the AFP and the CAFP. You can earn CME credit. Our Spark discussion page allows for more discussion around some of the issues on COVID. In particular, are we opening soon enough or too soon? And what should small practices be doing financially to move forward in this time frame? The CAFP's Family Medicine Clinical Forum will be November 13 through 15. We will have both a live face-to-face forum and a virtual forum. So we will be live streaming part of the meeting. Check on our website for more information about the forum. We look forward to seeing you in Long Beach. And then 2 weeks from now, beginning with this week, we're going to go every other week with this community conversation. Next Sunday, happy Father's Day. And on Sunday, the 28th, we'll be doing away from the clinical and talking about family medicine and the arts. And Dr. Mwazambawa will be hosting that with Josh Lunsford, CAFP's Director of Membership and Member Services. Again, we want to thank you for being with us tonight. Sorry we have a little bit shorter time frame this evening, but we will catch up with you in 2 weeks. Good night all, and have a great week next week. Be careful out there.